We're all set? Okay. Good afternoon, everybody. And thank you for joining us for our Psychiatry Grand Rounds today. I'm very excited about this talk that you were about to experience together. I would first love to introduce our speaker after covering a little bit of housekeeping. Just a couple of things. Number one, you will receive a request for evaluation at the conclusion of this session if you're on Zoom. That link will be put in the chat as well as emailed to you. If you're here in the room, of course, we'll have a QR code up on the screen. Please also feel free to engage in the Q&A session afterward. I think this is going to be a very interesting talk, and I know our speaker would really welcome questions and conversation afterward. So even if you just open the page for the evaluation and then come back to it later, just be sure we don't waste any seconds with her. And then the second thing for housekeeping is, what do I usually say is the second thing of housekeeping? Oh, the chat. Thank you. I was going to say the second thing of housekeeping is that no one listens to my housekeeping, but apparently one of our residents does. If you have questions throughout the course of the session, you can go ahead and put them in the Q&A if you're here on Zoom. And if you're in the room, please rest assured I will moderate fairly and expansively at the end of the session. I am told we have ambient mics, so we don't need to have Sean running up and down the aisle, although that mostly is good for entertainment. But we won't have to do that today. We will welcome your questions at the end. Without further ado, I'm very excited to introduce our speaker today, Rinad Beidas, who is the chair and Ralph Seal Paffenbarger Professor of Medical Social Sciences at the Feinberg School of Medicine at Northwestern. Previously, she served as founding director of the University of Pennsylvania Implementation Science Center at the Leonard Davis Institute, and the director of the Penn Medicine Nudge Unit. Dr. Beidas's research leverages insights from implementation science and behavioral economics to make it easier for clinicians, leaders, and organizations to use best practices to promote the quality and equity of care and also to enhance health outcomes. She leads the Ideas to Implementation team, which strives to transform health innovations into real-world change. The team works across areas including mental health, firearm safety promotion, cancer, HIV, and cardiovascular disease, and collaborates closely with key constituents, including patients and families, clinicians, health systems leaders, payers, and policymakers. As an international leader in implementation science, Dr. Beidas has published more than 300 peer-reviewed publications in journals that you may have heard of, such as JAMA, New England Journal of Medicine, Catalyst, and Implementation Science. She's led 2 NIH centers on behavioral economics and implementation science with a very strong record of NIH-funded implementation research, serving as MPI or PI of 14 grants, totaling about $45 million. I just started doing the math to see if our salaries comprise $45 million. Probably not. She has been identified as one of the top 10 implementation scientists nationally and is deputy editor-in-chief of the flagship journal for the field, also called Implementation Science. Currently appointed a member of the National Advisory Mental Health Council, she also serves on the Scientific Advisory Board for AIM Youth Mental Health Foundation and the Klingstein Third Generation Foundation. She previously served on the NASM study, Blueprint for a National Prevention Infrastructure for Behavioral Health Disorders. Dr. Beidas holds her undergraduate degree in psychology from Colgate, her doctoral degree in psychology from Temple. She's the recipient of a number of awards that I won't go into all the detail of. She has requested a short intro because she really wants to pack this session full. But I hope you can appreciate what an established and esteemed scholar we have in our midst today. We're very excited to welcome you. And even our chair, I think, just heard you give a talk last week and said he's very excited for your session and wondered whose grand idea it was to invite you here. So we're very happy to have you. And without further ado, I'll hand it off to Dr. Beidas.
Thank you so much for that kind introduction. This talk is a long time coming. I think Dr. Polchuk initially made the connection a while ago, and then we decided to do it virtually. I wish I could be there with you all. But it snowed yesterday and today. So who knows if I would have even have been able to make it in person had we planned it in person. So I have a lot planned. I'm going to jump right into the talk. I am going to try to cover a wide span of our portfolio and learnings over the past 2 decades doing this work and save some time for questions. Can someone just give me a verbal confirmation that you're seeing the right opening slide without the presenter view?
Yeah.
Great. All right, let's jump in. see if perfect. So I've organized this talk into kind of 4 chapters. So I'll start with telling you just a little bit about me and why I'm so passionate about implementation science. And then we'll do some level setting about what implementation science is, learnings from our team, and what brings me hope about the future. So let's start with the opening, although with that very kind introduction, I shouldn't need to spend too much time here. I do like to start all of my talks by situating myself and my identities and lived experiences. So you can see some of my identities in this picture here. I immigrated here when I was 2 years old from Jordan. I'm trained as a clinical psychologist. I'm a mother, I'm a PhD, and I'm really excited about implementation science as a tool. I really see it as a way that we can advocate and amplify the needs of our communities in pursuit of achieving population health at scale. And my earliest memories are of listening to my dad, who's a physician and was working in a safety net hospital in Brooklyn on the front lines of the HIV epidemic, telling me about the access and quality challenges his patients faced. And so that really was like the seedling of how I came to implementation science and my deep desire to really ensure that all people have an opportunity to achieve health. In addition to those initial seeds that my father helped plant, I really feel that my clinical observations kind of amplified, brightened my North Star in terms of where I wanted to spend my career focusing. So those clinical observations are so valuable. I trained in a lab that developed a treatment that you all may be familiar with for pediatric anxiety. It's called the coping cat. And while I was in that lab, I saw a lot of young people who had anxiety. And I'm going to share a brief story about a young person who came. At the time, she was 16 years old, lots of different anxiety disorders. And the most important thing about this story is that she had seen a number of therapists in the community who hadn't used cognitive behavioral therapy. And so she was really kind of hopeless and not sure that therapy could be helpful for her. I saw this pattern happen over and over again. And this is just a picture of what this young person was able to accomplish after an adequate dosage of the gold standard treatment. And you can see there that, the things that were very difficult for her before coming to treatment, like going to school, participating in choir, getting her teeth checked, became things that she was able to manage and thrive. And so I became really interested in this question of why are kids not getting CBT in community settings? Why do they have to come to an efficacy kind of randomized controlled trial university-based clinic? And it really changed the trajectory of my career. So I'm very grateful to those early observations and the support of my mentorship team, which allowed me to really pivot into implementation science, which was very much taking off kind of while I was in graduate school. Now, of course, my observation as a graduate student reflects a broader kind of science-wide issue, is how I should put it. As a society, we invest far more in discovery than implementation. I like to share the paper on the left to make the point that, we have an editorial in Science several years ago now, led by my colleagues, Dr. Proctor and Dr. Gang, calling out that COVID-19 showed the world that knowing what to do doesn't ensure doing what we know. That for me was a really important inflection point of, implementation science landing in our, some of our most esteemed journals. I also really like the paper on the right by Paul Thiel and colleagues, which was done in 2020 before the emergency use authorization for the COVID-19 vaccine. And in the simulation study, what they were able to show was that the set of implementation factors would be more important than the biological efficacy of the vaccine itself on population health outcomes. And I think we spend all this time focusing on biological efficacy and mechanisms, and that discovery is really important, but we have to spend equal attention to getting that discovery out to people so that your partner, your child, your family member, you can benefit from the very best science, because science is a public good. And we need to ensure that we quickly get best practices out into the community, and vice versa, adopts high quality community practices. Now let's talk a little bit about implementation science because I talk to a lot of people about implementation science, and there's a wide variety, given that it's still a kind of field in its adolescence of perspectives on what it is. So for me, implementation science is all about making sure that all people are getting the things that work out in the real world, whatever that setting might be, or moving the needle for all people in health. I have a great colleague, Dr. Curran, who has written some nice pieces kind of simplifying the jargon of our fields. Another way to think about this is we help people and places do high quality things, and we close gaps, whether they're no-do gaps or research to practice gaps or practice to research gaps. I do like to share a textbook definition for those of you who may want something a little more technical than what I just said. So I'll just call out a couple of points from this definition as you read it that I think are particularly important. The first is that implementation science is a scientific study of the methods that we use to help people and places adopt, integrate various things, whether they're practices, interventions, or policies, into routine healthcare and public health settings with the end goal to improve population health for all people. There's lots of different things that we might be trying to implement. And the fact of the matter is we're actually implementing things all the time. And so there's a great opportunity to think about bringing this lens to all of our implementation efforts. We do have our own set of assumptions and foci that differ a bit from what you might be traditionally used to in the biomedical research paradigm. The first, and this of course is changing in applied research generally, but is really foundational to implementation science, is that the work must be done in partnership with our communities. So I do like to share this story. Earlier on in my training. I had a K award. I was working in the city of Philadelphia, and I knew the coping cat really, really well. And I went and visited with my mentor a bunch of community mental health clinics in Philadelphia. And I said, well, I have this great treatment, and would you be interested in partnering on implementation of this treatment? And at the time, while they were very interested in hearing about my expertise, they had other problems that they needed me to help them solve. And so I learned very quickly that I really needed to be partnering and embedded within communities, answering their pain points and their priorities. Second, our outcomes are different. We tend to focus on clinician behavior within organizational constraints. That's another way to say we're helping people and places do the thing within whatever constraints they have in their environment. And we do measure effectiveness or health outcomes, but it's not our primary focus. And I'll say a little bit more about that when I introduce you to the implementation science subway. 3, we don't see context as a nuisance. So if you think about a phase 3 clinical trial with multi-sites and lots of patients, there's still really an emphasis on prioritizing internal validity, and context is something we want to minimize or control or use statistical methods to reduce the noise so that we can maximize the signal and understand and isolate the effect of our thing on our health outcomes. That's not how we see it in implementation. We see context as queen. We want to understand it. We want to measure it. We want to understand how it's related to outcomes and adapt and optimize for it. Often, when we're bringing an implementation science lens, we want to make sure that the thing that we're trying to study the implementation of is evidence-based, because we typically don't want to scale something before we know that it's going to work. There are new designs and trial designs that allow us to look at both effectiveness and implementation at the same time. But that is something that we typically want to be thinking about. And then finally, and this is something that I think is really important, we have specific frameworks, methods, and strategies, so you don't have to reinvent the wheel here. There's lots of literature for you to draw upon, even if there hasn't been work done in your particular evidence-based practice or area or condition or setting. The methods we use are kind of ubiquitous across contexts. I like to share this implementation science subway, which I co-developed with my colleagues, Dr. Lane Fall and Dr. Kern, to help people think about where they are with their work and where their questions fall. We typically start with a no-do gap and identify the practice of interest. Let's say we're using CBT for child anxiety. The first question we might want to ask is, has that thing shown efficacy? The answer to that is no, then you're really more in the kind of earlier stages of the work, but you should be thinking about involving end users, including clinicians and patients, and making sure that you design for implementation. Now, it happens that the answer to that question is yes, so then the next question you might ask yourself is whether or not that practice like CPT for child anxiety has shown effectiveness in a large trial in the real world with real world clinicians and patients without exclusion criteria. If the answer to that is no, you're doing more effectiveness, pragmatic research. Now, that by itself, if you're just studying, does my treatment work when real world clinicians and patients deliver and receive it, is not implementation. But if you start to ask questions like, does this treatment work? And also, what kinds of things made it hard or easy to do the treatment? Or what strategies might I use to accompany that treatment implementation? Then you're in the hybrid effectiveness implementation space, which you've heard me describe a bit in the previous slide. And so now we're in the green line of implementation science. The bottom green line is really the bread and butter of what we do in implementation. We go into context, we try to understand what might make it hard or easy to implement, design strategies to address those barriers and facilitators, and then do comparative effectiveness of those implementation strategies. And I'll show you some examples from our work in that space. And really, we're up a level. We're testing our strategies to help people and places do the thing, not the thing itself. One more way to think about what implementation science is, just to make sure this is aligning for everybody's mental model. We act as detectives or consultants and follow a series of steps in partnership with key constituents. So at the core, we have to engage with our communities, be embedded within our communities, and be answering questions of interest and supporting implementation efforts. We typically start by identifying a gap in partnership with our communities, select the thing that we want to implement to address that gap, understand the barriers or facilitators of what makes it hard or easy to do that particular thing. And then this is one of the magic spots. We then create an implementation plan using our established implementation strategies that directly tie to those things that make it hard or easy to implement, evaluate, iterate, and then sustain and keep that evidence-based practice going. So hopefully those different ways of explaining what kind of falls within the remit of implementation science is helpful. And I will say it's an evolving field. And so I know sometimes it can be challenging to kind of map the boundaries of the field. I think it's one of the fun aspects. We're still kind of discovering and finding how to do implementation. But I recognize for folks who are newer to the field, it can sometimes be challenging. All right, now that I've covered some of the background, I'm going to jump into my top learnings over the past 2 decades, and I'll be primarily giving you examples from behavioral health related work from our portfolio, although we do have lots of other areas that we cover, and I'm happy to talk about that. So I've foreshadowed this learning a little bit in my various comments over the course of the talk already, but if you want to have impact, one of the most important things that you can do is invest in authentic, deep, bi-directional partnerships with community, however you define that. That could be schools, that could be health systems, that could be community-based organizations or a healthcare delivery system. But this is really predicated under this belief, this deep belief that our communities are filled with wisdom. And as scientists who produce science as a public good, it is our responsibility to lead with the needs of our community, acknowledge the systems of power that are in place, and be filled with humility. So the types of questions I like to ask when I meet with our community partners are things like, what's keeping you up at night? How can I be helpful for you? How can I embed within your setting and advance a priority that is important to you? And what am I not seeing? What are the pain points? What are my blind spots? Those comments may be face valid, but I can't tell you how many times I've heard colleagues go into a setting and say, how can I do my study in your setting? Why don't you want to do my program? Why don't your clinicians want to do my program? And so I think really leading with that lens is very important. I won't cover this in great depth, but I just want to call out that the Patient-Centered Outcomes Research Institute has published and done some webinars on their foundational expectations for partnerships and research. And I think it really well defines the different kind of ways that we should be thinking about engaging partners. And of course, each of these reflects a continuum. But for example, when we do our studies, we think very carefully about how we are going to dedicate funds for engagement and partner compensation. when we work in health systems, we are very transparent about what funds are going to each health system, what funds coming to us as the coordinating implementation group, so that everybody knows how we're spending our resources and how we're supporting the various parties that are involved. And then one other just kind of key nugget from this is that it's not just enough to be that way at the beginning when we're starting the research, but we really want to think about embedding these values across the phases of implementation research, which happen before we start, while we're doing it, and after we do it. So many times I've heard partners be suspicious because they had had researchers come before and really prioritize whatever it was that researcher was trying to do and then kind of go away after the funding goes away. And we can't do that if we want to be meaningfully embedded and engaged within our community settings and offering science as a public good. I want to just give you a quick example of what's possible when you do this kind of embedded partnership. And I'm going to be really high level again because I'm trying to cover a lot in our portfolio. But I just want to show you the pictures of some of the people who were a part of this fantastic partnership that I had the privilege to be a part of in the city of Philadelphia from 2011 to 2022. I used to be at the University of Pennsylvania where I worked very closely with that group. And really, this work sprung from a 30-year partnership between the Center for Mental Health at Penn and the City of Philadelphia public behavioral health delivery system. And it was really predicated under this belief and value that the first commissioner, Dr. Arthur Evans, that you can see pictured all the way to the left, had, which was that there were all of these evidence-based practices that had been developed in the backyard of the public behavioral health delivery system in the city of Philadelphia. And he wanted to make sure that they were available to our community. And so what's really interesting about this example of partnership is that the Center for Mental Health and the City of Philadelphia team kind of came together in a community academic partnership, and we were embedded in helping the city think about how to advance that thinking, which happened in a phasic way. So early on, there were these initiatives that supported EBP delivery in various community-based organizations. Like there was the BEC initiative, there was the Prolonged Exposure initiative, and then Dr. Evans noted that there were a lot of similar barriers and facilitators, and many of the same organizations were participating in the same initiatives, but they were siloed. And so he developed and created the Evidence-Based Practice and Innovation Center, which ended up being kind of the backbone of my K23, which I'll share a little bit more about in a moment. And that evolved as we learned that really designating agencies and having an enhanced rate for clinicians who were providing evidence-based practices became a really important learning from our mixed methods work. And so, you can see how that partnership allowed for learning on both sides of the partnership. And, I just want to call out some of the benefits of these kinds of partnerships. So we had this iterative approach and we were doing rapid learning. Actual changes in policies and payment structures were made based on the work that we did together. And one of the most important things for me was that we were able to shine a spotlight and amplify the needs of our constituents. It also allowed us to show Philly as a national exemplar public behavioral health system, and it resulted in generalizable knowledge and scholarship. We were able to publish over 50 papers from this work, and there's lots of work that's continued as I've transitioned to another location. So that you can see the many benefits of really taking this very partnered approach. So the next thing after you think about that, who your partners are and where you can be most of use, is to pay close attention and listen. Because the initial questions that you come in with may not be the most meaningful ones that you end up pursuing. It really needs to be guided by that partnership. So I went into that relationship in the city of Philadelphia really thinking about how we support therapists in doing cognitive behavioral therapy-based work with young people in the public system. And I had the opportunity to really have a front seat at understanding how a system supports people in places. And it was really more naturalistic and observational. I wasn't implementing anything. I was really there to see what the factors were in terms of what clinician factors, what organizational factors were related to success for implementing agencies. And so we were able to write that paper, which was the paper that I, hypothesized I would write as part of my K23. You can see that below. But really the most interesting things were when we started to take a magnifying glass to the infrastructure and hear from constituents on the ground what their needs were and what they were experiencing. Here's an example of some of that work led by colleagues, Dr. Becca Stewart, Dr. Danny Adams, Dr. Brianna Last. Um, we learned about financial strain and stress, not just for the organizations themselves. We heard things from our administrators like, we're losing our shirt. We hold our breath and pray every month when we pay people, but also that the clinicians themselves were experiencing significant financial precarity. Many of them reported going without health care for themselves due to their low wages. And so we didn't go into this study thinking we were going to learn about financial strain and stress, but we heard it loud and clear and saw it in both our quantitative and qualitative work, and we were able to take a spotlight to that. And that really allowed us to develop a mental model of kind of Maslow's hierarchy of needs for community mental health clinics, where there was a real desire to do evidence-based practice, but it's kind of like self-actualization. If you're not able to keep the light on, stay compliant with regulations, and retain your workforce, it becomes very difficult to think about these kind of higher order matters like implementing a new evidence-based practice. And so it really allowed us to kind of reconceptualize how we thought of things. When I went into the field, there was a lot of talk about clinician resistance and not wanting to do treatments, when it really allowed us to understand that the people were doing the best that they could with the resources that they had within their organizations. And those experiences really shifted us towards how we thought about designing future studies to better support clinicians. So instead of assuming what clinicians might need, we asked ourselves, what if we asked them directly and empowered them as the experts? And so we did this really cool thing, an innovation tournament where we crowdsourced ideas from clinicians across our entire system and asked them, what do you need to implement evidence-based practices? And you can see the picture here from the tournament, and the winning clinicians, and our commissioner was there. And it was a really special moment. People brought their partners and their bosses to say, actually clinicians hold the keys to understanding how to better implement evidence-based practices. For example, a better waiting room experience. Many of the waiting rooms were chaotic and not relaxing, and clinicians reported, that sometimes their patients would come in and they'd need some time to kind of get regulated after their experience in the waiting room. So a better waiting room experience could really help support people and places do the thing. And we also heard a lot about financial incentives, which tracks back to that research I shared with you about the financial strain. So desire for prep time, paying for sessions, certification bonus. And some of those ideas are actually what went into place as the system supported people and places. So you can see that kind of rapid iteration. So often people ask me, well, there aren't unlimited resources. So if you had to decide like how you were going to support people and places and do evidence-based practices to enhance implementation success, what would you focus on? And it's really interesting because when you look at the early literature, we spent a lot of time trying to train clinicians and get them up to speed, when really I think it's the organizational factors play an outsized role in thinking about how to support people and places do evidence-based practices. This was some of our early work. Now it's been a decade since we've published this, but this was our first kind of foray in that same Philadelphia system. And what we did here was we looked at the set of clinician factors like their knowledge, their attitudes, their self-efficacy. And this is across hundreds of clinicians in 30 practices over, this is cross-sectional, but our work was over multiple time points. And then we looked at a set of organizational factors like their organizational culture and climate, the leadership. And we asked which set of factors explain more of the variance in clinicians' self-reported use of evidence-based practice. And what we found in this paper was that those organizational factors explain more of the variance than the individual clinician factors themselves. We also looked at this in different ways, different longitudinal ways. And so what you can see here are 3 waves of data collection over 5 years. And on the y-axis, you can see clinician-reported use of CBT techniques in their sessions. And the really important point that you can see here is that the agencies that had more proficient organizational cultures at baseline, so those are agencies that expected their therapists to be responsive to client needs, have up-to-date knowledge, and be highly competent, they showed a more steep slope in their increased use of evidence-based practices over time. So that's another signal that those organizational factors are really important in predicting who will go on to be successful in using these evidence-based practices. But for those of you who are listening carefully, you might say, well, that's therapist self-report, so there's lots of limitations to that work. I hear you. So here's a hard outcome. This is turnover in community-based organizations in Philadelphia, which is a big problem in kind of social science, social organizations that are providing services. What you can see here on the x-axis is proficiency culture, that same construct that I was just talking about in the previous slide. And higher scores mean higher proficiency culture. So 50 is the average, each standard deviation is 10, so the higher you go, the better your proficiency culture. So what you see here is that that's predictive of time 3 clinician turnover. So at time 2, that proficiency culture is predictive of time 3 clinician turnover, where you see much lower turnover in the agencies who have that high proficiency culture. So that's another really good indicator that the organizational factors are really important determinants, and we tend to not pay attention to them because they are hard and they are hard to change, but they're really important for us to be thinking about. Another really important learning from our work is that we have to make sure that our implementation approaches do not make it harder for people and places to do their jobs. That is what brought me to the intersection of behavioral economics and implementation science. And I'm going to tell you more about behavioral economics just to make sure that everybody knows what I mean when I say that. But that work really stemmed from kind of two big experiences. One is that, we invested so much time, energy, money in supporting people and places in doing evidence-based practices in Philly, but I couldn't help but feel like we might be making things harder for them. And you can see here a headline that actually came out of my K23 work, which I don't know is completely fair because we did see change in behavior, but from all of the mixed methods work that I described, we were hearing about the tremendous challenges in delivering mental health care in the public system, even in a system that was so supportive. I also had the privilege to lead the first behavioral design team embedded within a health system at Penn Medicine, the Nudge Unit. And so I got to see some of these principles at the intersection of behavioral economics and implementation science in action, and think that there's a lot of synergy and opportunity to bring that thinking to implementation science, which in its early years was kind of more focused on bringing a kitchen sink approach to all the things that might make it hard or easy to do a particular practice. So what is behavioral economics? I'd like to start by clearing up a common misconception that I actually had initially, and I was really fortunate. Penn has an incredible group, Chive, that is one of the world's leaders in thinking about bringing behavioral economics to health, and I learned from them. But behavioral economics does not equal financial incentives. And so I came to behavioral economics actually because of some of that work I was sharing with you, that therapists were telling us that they needed more financial incentives to do their work. But I learned the depth of what behavioral economics is, and I'm going to kind of illustrate it to you now. So this is the picture here depicts two urinals at an airport in Amsterdam. And I'm going to bring your attention to this little blurry thing that you see right there in that urinal, which happens to be a fly. And this is a great example of designing an environment to make it more likely that individuals using the urinal will use that fly as a target and keep the urinal more clean. So you can see here then that makes it more fun to use the bathroom, and also results in a desired behavior, which is a more clean experience. Here's another example. In London, they wanted to shift people's behavior around littering their cigarette butts. And so rather than just having lots of trash cans, which would be another kind of choice architecture design environment idea, they actually created this fun little who's the best soccer player in the world, Ronaldo or Messi, to encourage people to kind of vote with their cigarette butts. One more example from the digital world. If we were together, I'd ask you to all raise your hand. Who here has gotten stuck in an endless loop of watching the next show on Netflix? I'm going to raise my hand. That is because the power of the default, which comes from behavioral economics. So we tend as humans not to kind of, if something's happening, to just kind of go with it. And that's what happens. And that's what this digital digital experience is taking advantage of. If it just plays the next episode, you're likely to continue watching. So I was really interested in first making sure that our efforts to improve care could not make a difficult job harder, but also how we could redesign environments to support behavior change to make it easier for people to do the right thing, rather than my earlier observation that at times when we were implementing evidence-based practices, we were making things harder. So I really wanted to take some of those principles into the implementation science space. And I think this is one of the most powerful illustrations of how those principles really can shape behavior. So this is work from Dr. Mitesh Patel and colleagues, the founding director of the Nudge Unit at Penn Medicine. And again, I'm going to show you the power of the default. So what you see on this graph is on the x-axis, you see dates. On the y-axis, you see percentage of medications ordered as generic in the electronic health record. So prior to this date on 11/15/2014, you see a lot of heterogeneity in that ordering process. On this date, there was a change made in the electronic health record where the default became generic medicines. And what do you see? You see a huge change and much more uniformity where most of the medications ordered as generic increase. And then there's one medication which clinicians prefer to prescribe the name brand formulation. That happens to be Synthroid. And so you see that clinicians have the agency to change if they feel that that's clinically indicated, but that default really shapes their prescribing behavior. So that really kind of guided our kind of thinking about how we might bring some of these concepts into implementation science. And so there's been some great work and reviews done. This nudge ladder is a really nice way to think about some strategies or interventions to support people and places in doing the things that you don't traditionally see in implementation science. And so I think bringing some of this work into the implementation science space is really, really valuable. Because of how fun and attractive this kind of thinking and work is, I just want to call out that we should incorporate more of this thinking into our work, but it's not a silver bullet. And here's some just kind of principles that I've learned over the years. But I want to get to our last example before I talk a little bit about the future and open it up to questions. So maybe my most important learning is that it's really important to apply implementation science to no-do gaps where you can have the greatest impact. That's how I've really made decisions about what studies to do. And so I'm going to walk you through this whole cycle with a set of studies that our team has done. And I'm going to start with first what the gap is. So firearms are now the leading cause of death in the United States for young people, and they're among the most lethal methods for suicide attempts. And I know you all have incredible colleagues doing work in suicide prevention. This is really, really important work. 1 in 3 homes in the United States has firearms. And only 3 in 10 families store their guns unloaded and locked with the ammunition stored separately. So this really offers a modifiable target for firearm injury and death here in the United States. And there's been some great simulation work that demonstrates that even a modest increase in secure firearm storage could prevent up to 32% of firearm deaths in young people. And that's really the kind of gap that we're trying to get at. Pediatric primary care, and if there are any primary care clinicians in the room, I know you have to do so many things in the context of a well child visit, but it really is a prime point for intervention. And the American Academy of Pediatrics urges pediatricians to counsel around secure firearm storage. And so that was the setting that we were really interested in. And when we started this work in 2016, the first thing that we did was to do a survey of a number of clinicians within 2 health systems and to find out whether or not they were delivering kind of the evidence-based components of secure firearm storage interventions. Which happened to be screening. And I'm going to talk about screening a little bit more because we actually don't do that anymore. But when we were doing this study, that was a key component. Having a conversation with parents about the importance of secure storage and offering a cable lock, which may be the most important ingredient of the kind of common to these interventions. And what you can see here is that most clinicians are not engaging in these activities most of the time or always, which again, further helps us understand what the gap is here. Firearms the leading cause of death, and we have an evidence-based program that's not being used. The next stage would be to select the thing. There was already an existing evidence-based program that had been tested in a large-scale randomized control trial by Dr. Sherry Barkin and colleagues in pediatric practices around the country. We ended up adapting that program, and I'm not going to go into those details because of time. And the program now represents a brief conversation with all parents, not screened parents, but all parents about the importance of secure firearm storage and offering free cable locks at well child visits. The next step is to understand what might make it hard or easy to use that program. And so to do that, we conducted 70 semi-structured interviews and used an established framework from implementation research called the Consolidated Framework for Implementation Research, which helps you think about the different ecological domains that might be important when you're engaging in implementation. And this is work led by my colleagues, Dr. Wolk and Dr. Jaegerheimen. And we heard in those interviews the importance of having a brief program, so less than a minute, attending to clinicians' self-efficacy, making sure that the program was integrated into the workflow, primarily the electronic health record, and that leaders endorsed it, and also attending to the fact that there's different firearm culture in different regions. So using that information, we used a systematic method called implementation mapping to derive implementation strategies that would address what we learned in that kind of mixed methods diagnostic work in the settings in which we were hoping to implement. So one of our conditions really centered using the electronic health record to integrate in the program into the workflow and building off that behavioral economics kind of literature. And so you can see here an example. We built into the documentation template for the well child visit a reminder or prompt for the clinician to discuss secure firearm storage and to offer a cable lock. And then the other condition that we were interested in testing was that same electronic health record change plus something called facilitation, which is essentially problem solving and implementation support for individual clinics. And you can see our colleagues who led that process. So the next stage in our detective cycle is to evaluate if our approach worked. So again, the study design we were using here really explicitly incorporated the ideas we had about the importance of supporting organizations as well as making it easier for clinicians to deliver a program. This is a hybrid type 3 effectiveness implementation trials in 30 clinics and almost 400 clinicians and almost 50,000 well child visits. 15 clinics just got the change to the EHR. 15 clinics got the change to the EHR plus facilitation. All the clinics received initial brief training as part of their typical training processes. And we were hoping to answer which condition was more effective at supporting people and places and doing the thing. The less costly and more scalable kind of EHR change, or is it needed to provide that more intensive support to the organizations given potential barriers? What you can see here is that a higher percentage of well child visits received the whole program, so a discussion about secure storage and an offer of a lock in the Nudge Plus condition that had both the EHR change and facilitation compared to those in the Nudge only arm. So we're really proud we were able to get up to half of those visits to include the entire program. And at baseline, we estimate based on survey response that less than 2% of clinicians are offering this program kind of in standard usual care. So that's a pretty significant change, and we're pretty excited about that. And the last step is seeing if the approach continues to work. And this slide just is preliminary analysis. We haven't published yet. But there is a small drop in implementation behavior in the sustainment period, but clinicians are still delivering the program at high rates. We're now adapting this work to do it in safety net clinics in Illinois, as well as expanding it into adult primary care and women's health in the health systems that we worked with in the original trial at Henry Ford in Michigan and Kaiser Permanente, Colorado. So really excited kind of about the next stages of this work. All right, I'm going to bring us home. And I see something in the chat, but I'm going to ignore it because I want to get through the final few slides. I have a lot of hope about the future. I think implementation science is a valuable tool in our toolkit to achieve health for all people. I think we've also learned a lot over the past 20 years about where the field has gone and where it should go. These are some of my recent papers that kind of elucidate how I and other colleagues are kind of thinking about the future of the field. And I've just distilled it down to a few key points. One, design for dissemination and implementation as early as possible. I know that there's some treatment developers, basic scientists perhaps in the audience, and I think it's so important that we get upstream so we're not trying to solve for what makes it hard or easy to implement at the end of the translational research continuum. We must co-design the interventions to center the voice of the people who are going to be receiving or delivering that program, and making sure that the context in which they play, work, and live is prioritized. And so human-centered design is really, really important. Here are some colleagues, Dr. Andrea Graham and Dr. Erin Lyon, who are leaders in thinking about how to do this within intervention and implementation design. And I just want to make sure that we don't produce these beautiful programs that are like this impossible teapot. It's beautiful to look at, but if you were to try to pour hot water out of there, it would not be ideal for use. Second, I really would like us to get a little bit faster in getting our treatments to people who need them. So we need to make sure our approaches are fast, nimble, and rigorous. I argue with my colleagues pictured here, Dr. Lisa Saldana and Dr. Rachel Shelton, that whenever it's safe and possible, particularly when we're using programs with established kind of ingredients or components, that we move right to effectiveness trials, as the most valid test of an intervention is the test of that intervention in the context in which it is intended. I'm less interested in knowing if in a pristine environment an intervention will work. I'm much more interested in knowing if it can work where real patients and clinicians are functioning. There has been an increasing interest in these hybrid effectiveness implementation studies that I mentioned. And I would argue that whenever you do an effectiveness study, we're doing things to support implementation. So we should probably be really bringing that implementation lens to that work. And track what you're doing to implement to move us along more quickly, so that we're learning from that earlier work of the continuum when we get to implementation. This project led by Dr. Brittany Rudd demonstrated, she basically coded a number of suicide prevention projects for implementation strategies that were pragmatic effectiveness studies. And in the literature, very few implementation strategies were reported in the publication. That's that lighter blue box. And then she actually reached out to the principal investigator and asked them to endorse which implementation strategies they used. And in the dark blue box, you can see that they actually ended up using a set of implementation strategies that were not reported. And that makes sense because there weren't recommendations to report them when this work was being done. But we think there's a real opportunity to move faster and make sure that we're getting information on implementation from the beginning. My last point is that the next generation of researchers show us that the future is bright. There are many inspiring investigators leading creative and transdisciplinary work to meet the needs of our communities in implementation science. And I bet I could give my whole talk on all of these incredible folks and folks not pictured here. So that brings me a lot of hope about the future. And I want to thank the incredible team, my family team, as well as my lab team who make this work possible that I shared today. As you saw, it takes a village to do this work, and I'm here presenting on behalf of many people who led components of this work. The department that I lead at Northwestern in the Feinberg School of Medicine, it's called the Department of Medical Social Sciences. We have training institutes. So if what you heard today sounds interesting, we have an annual Implementation Science Academy. We have an upcoming Positive Health Interventions Institute led by my colleagues, Dr. Judy Moskowitz and Dr. Liz Addington. So if you'd like to learn more about that, definitely reach out to me. And I'm really proud of myself because I got through a lot of slides and we have 10 minutes left for question and answer. So these are the ways that you can reach me if you have any questions. And I'm going to go ahead and stop share and hand it back over to the moderator.
It's me again. I'm your host, cruise director and moderator. Thank you so much, Dr. Beidas. As a person who thinks she knows much and does maybe a small fraction of the things that I think I know, this really hits home in a number of ways. And I think the helplessness that a lot of us feel about overcoming some of the environmental and organizational challenges to close that gap. I just really appreciate your very thought-provoking talk. We have one question on the Q&A, which I'll start with, and then I'll take questions here from the audience. The first is from Dr. Polishuk, who says, thank you very much for sharing your amazing work with us here. Could you say a little bit more about how you've incorporated stakeholder engagement to co-design programs? I think that is a really vital ingredient that many of us in this room may feel in our hearts, but might have a hard time knowing how to do.
Yeah, I mean, there's a whole area of science. Thank you, Dr. Polishuk, for that great question. That really leans on thinking about participatory approaches from end to end, right? So I'll give you an example from our work that I described as I presented. But I think the key here is to identify collaborators who have that experience and to embody that value at every stage, similar to kind of that slide I showed with the before research, during research, after research. So that safe firearm program I described, I presented it as linear. It wasn't quite linear, but for the purpose of getting through it quickly, it's kind of easier to talk about it that way. But we basically took that program and we engaged with stakeholders to adapt it and modify it to make it fit the context. And I really believe that process of engaging with our stakeholders, and I prefer to use constituent language, so those constituents made it the success that it was. And one of the things you heard me talk about, those kind of 70 interviews, as well as engaging with community advisory boards that various colleagues had representing perspectives of different people who might be impacted by firearm injury, is thinking really carefully, doing a constituent map. Who are all the people who might be impacted by implementation? And I actually, lesson learned, when I initially scoped out, that was first an R21 that led to an R01, didn't include firearm rights advocates, firearm safety course instructors as part of our kind of group to interview. And what happened as I started talking to various constituents is we realized we left a group out. And they were such critical voices in helping us adapt a program and make it acceptable across the board. And I'll tell you, we got very few complaints across 50,000 well-child visits about pediatricians having this conversation because we had so much input. And so I just think that at whatever stage you're in, making sure that you map out who the constituents are, that you engage with them early and often, and that you design for them and their context is really important. And there's all kinds of nuances to know, like whose voice do you center and how do you deal with disparate opinions and all sorts of things. But there is a science of engagement, participatory action, community-based participatory research that can really help guide you in that process.
Excellent. Thank you so much. We do have a couple of other questions rolling in on chat, but I just want to pause and see who in the room might have questions as well. Yes. You can just go ahead and shout it from the rooftops.
So I am a peer, as well as my friend Ashley here, in emergency psychiatry. And we are trying to expand the use of peers on CPEP. And so we have all these ideas of how to do that. Like we're going to meet with the residents. And then, because we feel like if we start with people that are, in beginning their career, it might be helpful. But I think the implementation, like, I wonder if there are other things we should be doing. We also are going to be meeting with medical students who are interested in psychiatry as well. But I know, and we've also done things like publish the names of all of the doctors, nurses, and social workers who used peers because we have a referral system. But we still want more referrals. And I'm just not sure if there are other things we could be doing.
Yeah, that's such a great question. And I love the strategies that you all are using. And I think it really embodies something that I also believe is the future of the work, which is that I think it's really valuable to embed implementation science within health systems to address priorities of interest. So I hear you wanting to expand the use of peers and to get more referrals within emergency psychiatry. And if I were at your organization, I would kind of want to sit down and talk about a project where we could bring implementation science as a lens to the work that you're doing. And what I typically find is that systems, organizations tend to have typical ways that they do things, right? And it may be education, it may be training. And I think implementation science offers an additional new lens in which to think about implementation, as well as bringing a really systematic strategic process. And because so many implementations fail, I didn't share that data, but the majority of implementations end up failing. I think we deserve to bring the very best of the science. And so my hope of the future is that there would be implementation scientists on health system teams, part of quality. We're doing some work in our health system. For example, we're embedding and trying to help one of our regional hospitals reduce pressure injuries. And we brought that systematic circle that I showed you, we brought this process to that problem and have been working hand in hand with the leaders and the frontline clinicians to think about how to achieve that goal. And so, it's very data driven, which aligns nicely with quality and health system kind of metric approaches. But I do believe in talking to my colleagues that we bring a different lens and help people think through, first of all, the constituent mapping process, which often gets kind of not done, as well as the linking of those barriers to strategies that might help increase the desired behavior.
It's just so sensible, and I'm grateful for the way you're distilling it down and making it so accessible. We do have a couple of questions asking, in addition to the resources that you showed at Northwestern, what are some of the best ways to get advanced or additional training, and will you come here and train all of us?
Would love
I added that last part.
in the summer. But there's some great training opportunities nationwide at this point. The landscape looks very different than it did when I kind of first started doing this work. Of course, there are NIH-supported R25s. So I do want to call those out, especially the NIMH Implementation Research Institute. I'm lucky to serve as core faculty on that. I was a fellow once upon a time. That's where I got my training. And there's a couple of other NIH opportunities. And then if you look at the kind of national landscape, there's a number of universities that are offering certificates, short trainings. But I do want to call out that implementation science I'm trying to make it accessible, but it is difficult. It's not like I wouldn't go into a wet lab and pick up a pipette and try to do something with it because I would not know what to do, right? And so I think mentored and apprenticed opportunities to kind of really see what it looks like to do implementation science work is also a really important part of this. So, I think you can get so far with didactics and then I think you really need to collaborate. And many of my projects are hand in hand with, physician scientists who have expertise in the content area, and I bring the implementation expertise. So I think also you don't have to go it alone, identify partners who can bring that expertise.
Thank you. My last question for you comes from Dr. Van Orden, who says, thank you in all caps for this presentation. Do you have thoughts on how evidence on mechanisms of action for interventions can be leveraged to inform better implementation? This intuitively makes sense and is part of models like the NIH STAGE model, but what that might actually look like in practical terms may be a little bit less clear.
I need more than 1 minute to answer that, but I'll just quickly say that mechanisms of action for intervention science is critical because it helps us understand the core ingredients of the interventions and what needs to be core, what can be peripheral. And when I do my work, I break it up into you saw me saying screening, the conversation, the locks, because each component has different reactions from partners on the ground. And so that's really important. I'll also call out that implementation science is having a bit of a moment in mechanisms of action, and there's a lot of really great work being done in that space. If you look up Kara Lewis, she's published a lot on mechanisms for implementation strategies. And of course, this is where intervention science and implementation science kind of come back together. So a lot of opportunity in this area. Great question, Dr. Van Orden.
Terrific. Well, on behalf of our Department of Psychiatry and many people who are going to be part of that block of time, I request from your office, we're very grateful for your expertise, for your engageable presentation, and for being with us today. And I just want to say thank you so much.
Thanks for having me. Look forward to more collaboration.
Thank you. I'm auctioning off this Awala water bottle that it comes pre